Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And today I'm going to be talking about the assessment of people with low back pain. Low back pain being the most common cause for people claiming Social Security disability. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. Now, although low back pain is a very common problem, I often find it difficult to assess in Social Security patients, and there's a number of reasons for that. These reasons include, number one, no one can truly know the extent to which another person feels pain, or even if they feel pain at all. Number two, the low back is a deep structure, making it difficult to examine, unlike, say, the joints of the fingers or the ankle. The low back is under inches of skin, subcutaneous tissue, fat, and muscle, and therefore neither inspection nor palpation are very accurate. Third, no one really knows what causes most cases of low back pain. There's all sorts of things written in the literature, but just as things were 50 years ago when I started medical school, today we are no closer to understanding what exactly causes most cases of low back pain. The next problem is introduced by the reading of magnetic resonance imaging of the low back. As I've stated before, we're in the crazy situation in the United States where at least 99% of lumbar MRIs are read as abnormal, which means that the abnormal is the normal state of affairs. All sorts of problems are ascribed to these abnormalities on MRI, such as bulging or herniated discs. But the fact is that a huge number of patients have bulging or herniated discs on MRIs and have no low back symptoms whatsoever. So just as people make the argument that bulging or herniated discs are the cause of low back pain, one can make an equally valid argument that bulging and herniated discs prevent low back pain, since so many people who have them have no back issues. Because low back problems are so difficult to assess, and one must basically rely on the patient's word for what is wrong, low back pain is a gold mine for malingerers, both people looking for financial compensation and for prescription drug abusers. Now, as is well reported, most adults will have low back pain at some time in their life, and usually it will last for a couple of weeks to months and then go away regardless of what sort of treatment is given. But the patient population you'll see in Social Security exams is different. To qualify for Social Security disability, one must have a problem that has been present for at least 12 months or is expected to be present for at least 12 months. And therefore, one seeing the chronic low back pain patients. It's extremely rare to see a patient complaining of low back pain for less than 12 months. These patients tend to be worse off than the average low back pain patient you'd see in a general primary care physician. And they tend to have neurologic lesions at a higher rate than the average low back pain patient. Conversely, you will see some patients complaining of disability due to low back pain who have no back pathology at all and are simply malingering. Malingering is fairly rare in an average primary care practice, but is much higher in a disability practice. Finally, The questions posed in a Social Security exam are different from the questions posed in an average primary care practice. We're not that interested in how the low back pain developed, its history over the years, the various treatments that have been applied. What we want to focus on is what is the patient's condition now, not what it was 2 years ago when they had an auto accident, not what it might be in 6 months if they get some sort of treatment, but what sort of problems do they have today that interferes with their ability to work. And the work abilities that are related to low back pain include the abilities to sit, stand, walk, lift, carry, especially heavy lifting and carrying, and also balance. I do see a fair number of patients with back pain with neurological lesions who have impaired balance, and that can really affect the ability to work. For example, a patient with impaired balance who's prone to falling can't work on ladders, near dangerous machinery, or on roofs. So I'm going to talk about my approach to evaluating these sorts of patients. And it begins when I first see the patient, which is usually when they enter the room. I'm looking for any difficulties with gait, any problems sitting down in a chair, and any problems remaining in a chair. Some patients with severe back pain can't sit for more than 5 minutes or so. Obtaining a good history can sometimes be a problem. A lot of patients, when they're asked what's making them disabled, will simply say, "my back." Well, that's not enough information. They haven't even told you if their back hurts. You need to get the patient to describe what problems their back is posing for them and how those issues make it difficult for them to work. Sometimes when I just can't get the patient focused in this regard, I ask them, suppose somebody called you up today and said, "I have a job for you. You start tomorrow. Why couldn't you take that job?" The next thing is that when asked about the back, patients will often give a description of their MRI, and I find that basically useless because, as I stated, abnormal MRIs are common in folks with no back problems whatsoever. You need to get the patient steered in the direction of telling you what their symptoms are and how those symptoms affect their ability to work. And then another problem is often these patients have picked up a lot of medical jargon. They'll tell you that their back pain radiates. Well, when another physician says a pain radiates, I know what they mean, but I don't know what a patient means when they say radiates, and it's important to get them to describe their issues in their own words. Another important thing to ask about is what makes the pain better or worse. For a patient to qualify as disabled, generally their pain has to be made worse by some sort of work-related activity. I've given an example before of a patient who told me that they had terrible pain all of the time and nothing ever made it better or worse. They were sitting comfortably in a chair telling me this. So I asked them, well, if the pain is always the same and nothing you do makes it better or worse, why can't you go to work instead of staying home? And they had no response. Another thing that's important to point out is that people don't qualify for Social Security disability based on their MRI reports. Social Security uses MRI reports as an adjunct to confirm that the patient has a back problem, but not as a diagnostic measure. It's important not to lead the patient in the history so that they give the responses they think you want. A good question to ask is what makes the pain worse? I'm especially interested if the patient says something like coughing or sneezing makes it worse, or if they can't tie their shoes, for example. In terms of aggravating or relieving factors, it's good to know that the pressure on the intervertebral discs is lowest lying in a supine position, next lowest lying on the side, third lowest sitting, fourth lowest standing, fifth lowest standing lifting something, and highest sitting lifting something in front of you that's heavy. It's also important to know that neurological lesions due to low back problems, such as sciatica, go downwards, not upwards. I had a patient once tell me that their low back pain shot up to the top of their head and then out to their eyeballs. Well, the human nervous system simply isn't wired that way, and therefore their story was incredible. Now, when it comes to incredible histories, it's important to keep in mind that sometimes the patient will give an unusual or hard to believe history when they really have physical disease. And causes can include a patient who's inarticulate, has difficulty describing their symptoms, or, as I like to say, that their disease may not have read the textbook and is presenting in an atypical manner. Because you'll see so many low back pain patients in Social Security disability exams, sooner or later you'll see physical disease present in a very atypical manner. Now, when it comes to the physical exam, I have a patient sitting in a chair giving me a history, and then I ask them to walk across the room and sit down on the exam table. I pay particular attention to the way they rise from the chair. Some patients with severe back problems will have difficulty rising from a chair, and that's significant in the eyes of Social Security Administration. And if they do have difficulty rising from a chair, I always put that in my report. I do a lumbar range of motion test, which includes bending forward as far as possible, backwards as far as possible, and tilting to either side. Unfortunately, I find that cervical and lumbar spine and shoulder range of motion are the most common ranges of motion that patients will simulate or exaggerate their limitations in. So often it's not very helpful. Then I palpate the spine and I look for muscle spasm and I look for tenderness. One of the most reliable clues I found to patient simulation or exaggeration is overreaction to superficial touch over the spine. Remembering that the structures of the spine that are painful are deep, and simply lightly touching the skin or brushing one's fingers on the skin is not going to aggravate problems with the bones, discs, or nerves in the back. Conversely, if a low back pain patient says they have no tenderness at all, even when I press fairly hard, that means to me more likely that they're telling the truth, because I've seen a lot of patients with severe back problems who in fact didn't have any tenderness. Next, Social Security always wants to know about straight leg raising. In my screening range of motion exam, which I've described in another video, I have the patient do straight leg raising, first the right leg and then the left leg, while seated. If they are not complaining of back problems and they have no difficulty with that, I don't check straight leg raising in the supine position. However, if they do have pain with straight leg raising in the seated position, Social Security wants it checked in the supine position as well. If it's positive in the supine position, I also like to do Laseg's test, which is raising the leg to just the point where they start to have low back pain, then lowering it a few degrees, and then dorsiflexing the ankle. If that really exacerbates their low back pain or radicular symptoms, that's strong evidence for lumbar nerve root compression. The examiner needs to be careful when testing straight leg raising to make sure that the problem a patient has isn't tight hamstrings. Usually these patients, when asked where does it hurt when they lift their leg out straight, will point to the hamstring muscle. That is not a low back problem. That is not sciatica. You're looking for neurological type pain in the leg and in the low back. While the patient is sitting, I also examine the head, eyes, ears, nose, and throat, the neck, the lungs, the heart, and the sensation and strength in the arms and legs. And here, it's important to realize that the grade 4 out of 5 weakness has the broadest range of all grades of weakness. It can be anywhere from pretty severe to extremely mild. I find a good marker of patient simulation or exaggeration is if they have severe grade 4 out of 5 weakness in the legs during the exam, but walked in the room normally. In other words, they're demonstrating such weakness in the legs that they shouldn't be able to stand and walk after they've already demonstrated that they can stand and walk. Another sign of simulation or exaggeration is stocking distribution, hypoesthesia, or dysesthesia in the legs. Compression of the lumbar roots does not cause numbness of the entire leg. The numbness one gets isn't as clearly demarcated as is illustrated in textbooks, but if the whole leg is numb, something is going on besides lumbar radiculopathy. Now keep in mind, diabetes is very common, and diabetic neuropathy and low back problems can certainly coexist. And also alcoholism can cause a similar type of sensory loss in the legs. I should have mentioned this earlier, but from time to time I get younger men in their 30s or 40s complaining of back pain and disability who are clearly malingering and are obviously physically fit and lift weights. Now, I've treated a lot of weightlifters, bodybuilders, and powerlifters, and they certainly get a lot of muscular strains and sprains, including low back pain. However, I firmly believe that one cannot be a serious weightlifter and at the same time have such severe low back pain that one is unable to work. One physical finding that it's impossible to simulate or exaggerate is loss of reflexes. Usually in low back pain with radiculopathy, loss of the Achilles tendon reflex. And if you see this, that is very strong evidence that the patient has a neurological lesion due to their low back pain. Now, because one will be seeing more severe than typical back problems, you have to keep in mind the less common but serious problems related to the low back. The first being lumbar stenosis. Lumbar stenosis is a disease of the elderly, but you will see patients in their late 50s and 60s in Social Security disability exams, and some of them clearly have lumbar stenosis. The symptoms and signs are different compared to low back pain with sciatica or radiculopathy. Specifically, both legs often have neurological involvement. There may be physical findings in the legs such as weakness, unsteady gait, or loss of reflexes, which are quite different from those of lumbar radiculopathy. In fact, sometimes lumbar stenosis is misdiagnosed as intermittent claudication, and it's sometimes called pseudoclaudication. The patient with vascular claudication is likely to have a history of heavy smoking and abnormal pulses in the legs, either diminished or absent, and or an aortic or femoral bruit. The pain of vascular claudication is relieved when the patient stops walking and standing still. In contrast, the patient with lumbar stenosis and neurogenic claudication may not be a smoker, will likely have normal pulses in the legs, and if the pain is brought on by walking and the patient stands in an upright position, the pain isn't promptly relieved. The pain is relieved by sitting, lying down, or bending forward. Other less common but important diseases to recognize, which I've seen in Social Security disability exams, are number one, transverse myelitis. I had a patient who had a very severe transverse myelitis case, could barely stand and walk, and they told me that their disease had initially presented as simple low back pain, which they thought for several months merely meant that they'd sprained their back. A second problem is what's called double crush syndrome. This is when the patient has disease in the lumbar and cervical spine and neurological lesions at both levels. It stands to reason that somebody who's prone to arthritis in the spine might have it at more than one level. What's tricky is, first, this can present a confusing picture of mixed upper motor neuron and lower motor neuron signs in the legs. And second, sometimes the patient will have no neck complaints whatsoever. They will simply complain of low back pain and trouble with their legs. I find it helpful to check for Hoffman's and Babinski signs in confusing cases of low back pain. If either is present, that means that the patient has an upper motor neuron lesion, and this isn't a simple case of low back pain with sciatica or lumbar radiculopathy. Finally, this one sign on the exam, which I find very helpful in distinguishing organic from functional back pain, is how the patient rises from a supine position. I examine the abdomen with the patient supine, and I also examine the straight leg raising test, knee, ankle, and foot problems with the patient supine lying on their back. I then ask them to stand up, and I do my agility tests, such as walking on heels and toes and tandem walking. If the patient promptly sits straight up with no distress, like one does doing a sit-up, that's strong evidence against organic low back problems. Patients with low back pain quickly learn that the way to get up from a supine position is first to roll over on the side and then sit up sideways. I've had some low back problems myself, and I learned this on my own. You simply cannot sit up comfortably rising straight up from a supine position if your low back hurts. Finally, it's important to assess balance in patients with low back pain because in certain circumstances, such as leg numbness or severe weakness or bilateral nerve lesions, the balance may be impaired. And I do this two ways. The first is tandem walking. I have the patient do a heel-toe walk. And the second is the Romberg sign. If there's signs of impaired balance, it's very important to put this in your report. And lastly, Social Security considers neurological impairment with low back pain much more serious than low back pain alone. And they want to know, is it in one leg or both? So whenever I finish a report on a patient with low back pain, I put low back pain without signs of nerve compression, or low back pain with signs of nerve compression in one or the other leg, or in both legs. Well, I hope this has been helpful, and as always, remember, if it happens, it's possible.